Hi, everyone. Thank you for joining the webinar. We're going to give it just one more minute so that we give time for everyone to join. If anyone is having a problem, you can email me at aturner@tna-support.org, and I'll see what I can do to help. One more minute. Okay, looks like we've got a good number of attendees so far, and we've got a lot to cover, so I'd like to get started. Welcome to the Facial Pain Association's June webinar. My name is Amy Turner. I'm the Director of Development at the Facial Pain Association, but I'm also a patient with atypical trigeminal neuralgia. During this webinar, Dr. Jeffrey Brown, who's chairman of the FPA Medical Advisory Board, will interview Dr. Michael Lim, who is a newly elected member of the Medical Advisory Board. Dr. Lim is a professor of neurosurgery at Johns Hopkins University School of Medicine, as well as the director of Trigeminal Neuralgia Center, among other things. During the meeting, you can submit questions through the chat, and we'll try to get to as many as we can. We're limited on time, and we'd love to get to all the questions, but if we can't, I will try and send responses after the meeting to those we haven't gotten to. So with that, I am going to turn it over to Dr. Brown.
Good evening. I am going to start by asking Dr. Lim a question, which is how things begin anyhow. And I'll start with something that happened just in my office the other day. So a 32-year-old woman who's been having stabbing pain on the right side of her face for the past several months has seen her physician. He's told her she has something called trigeminal neuralgia, and she found the number for the Johns Hopkins Trigeminal Neuralgia Center and makes a phone call. So my next question to Dr. Lim is, what happens when someone picks up the phone?
Hi, Dr. Brown. So thank you. That's a great question. You know, every center and every place is different. You know, in what we've done at Johns Hopkins is we've created multiple ways to try to contact us. There is a trigeminal neuralgia center here, and when you look at for example, if you look it up in Google or on the web, you should be able to, it's easily findable, and there's a number that you can call. And when you call that number, oftentimes there's a person, well, there's always a person that greets you on the phone, or if not, they'll get back to you very shortly. And they usually ask you a series of questions or ask you to fill out a form. And then we look through the forms and get back to our patients and try to help, either if it's something that we can do, or if it's trigeminal neuralgia, or if it's not, try to get the patients into the right center, because we have many different specialists for different types of pain at the center. Also, you know, we are easily accessible. People can look up, you know, the doctors, and they can also easily get in touch with them too, of which then we usually get them back to the center to help figure out where to get them.
So they'll speak to a nurse, a physician's assistant, a secretary, and they will have a list of formal questions. Do they ask for like images? Do patients have to have images to come see a neurosurgeon at Johns Hopkins before they see you?
So in general, we don't usually ask for images in the beginning. Sometimes the patients can provide the images and or the reports. It would be helpful, but with trigeminal neuralgia, the majority of the time it's a clinical diagnosis. So most of the time with the form and the symptoms that patients describe on their reports, we can usually figure out if it's something that we can help the patients with at our center, or if need be, to get them to the right people either here or elsewhere.
So if they wind up seeing you, what's your decision-making process in determining whether they're, let's go right to the surgical thing. What's your decision-making process in your evaluation as to whether they require surgery from you for their facial pain?
That's a great question. So as I alluded to earlier, with trigeminal neuralgia, the diagnosis is made really at the time of the meeting, at the time you see each other in the clinics. And we look for, look for certain symptoms that you mentioned before. They're very classic symptoms of trigeminal neuralgia. People report sharp stabbing pain, electrical pain, that brings them to their knees. It's episodic. It's usually on one side of the face, and there are some triggers. And if patients fit that criteria, we at least explain that this diagnosis of trigeminal neuralgia is a clinical diagnosis. And then, in terms of the next steps, we do look at imaging, and usually the imaging is twofold. One is to rule out other causes of pain. We've seen people present with, for example, tumors like meningiomas or large acoustic neuromas that can cause facial pain. And the second reason for imaging is sometimes to look at the anatomy and look for things such as vascular contact. And that helps us in the next step, which is making recommendations for different sorts of treatment.
Let me show you a slide. Let me show you a slide, if I can get this to work. Hold a second. Can you see that on the screen?
Yes.
So it's got some red arrows to help you.
Mm-hmm.
But this is the same woman, say this 32-year-old woman, and this is an image that shows on the bottom left. You can describe what you see, or I'll just tell you what I put an arrow on. There's a dot next to her trigeminal nerve. I think I can use a pointer right there. Correct? Yeah. Can you see that?
Yes.
And here there's a blob, which is the trigeminal nerve, and then there's this other thing, which is an artery. And then there's the nerve, and there's an artery here. So without turning everybody into a neuroradiologist, what's your impression?
So, yeah, as you mentioned, this is a special type of imaging. It's what we call a skull base image. And in looking at it, it's looking for that anatomical, I don't want to call it an abnormality, but that anatomical association of a vessel touching the nerve. And if a vessel touches the nerve in an individual who presents with the classic symptoms of trigeminal neuralgia, one of the treatment options, which is something called the microvascular decompression, is something that could be a great option for patients. It tells us what sort of treatment options they best might benefit from when medicine failed.
Right into this about this kind of image. This isn't the standard kind of image that you would get if you went to your family doctor and they did a quote MRI. I don't think you would get this kind of imaging. You want to talk a little bit about what's unique about this kind of imaging that shows this picture? Right.
So when you, as you mentioned, when people get MRIs, they don't get a high resolution MRI typically as their first MRI, because it's usually a screening MRI. They're looking for abnormalities such as tumors or multiple sclerosis and other inflammatory conditions. And then if a patient suspects to have trigeminal neuralgia, oftentimes we order these scans or these images. And in a nutshell, they're called high resolution images. Different companies or manufacturers call them different protocols by trade name, but sometimes you may hear it called Fiesta or True FISP. And what it does is it allows us to look at the nerve with very fine resolution so that you can look for associations such as a vessel touching a nerve. And I think for trigeminal neuralgia with microvascular decompressions, which is a surgery that literally separates the artery from the nerve, being so successful, this is an important non-invasive test for patients when they decide to or not decide to do different treatments, to choose different treatments.
Let me ask, in this day and age, do you talk about exploring the nerve to see if there's a problem? Do you still have to explore, or do you know what you're looking for before you operate?
So that's a great point. Anytime someone gets a diagnostic test, there's something called sensitivity and specificity. And sensitivity is kind of the thing that most people think about. When this test is positive, how truly positive is that test? And so, these MRIs are very, very accurate or very sensitive. Usually about 90 to 95% of the time, there is the association that is seen on the MRI is seen in real life when we're doing surgery. So most people use this as a guide, and if you don't see a clear contact, or if it's clearly not touching the nerve, that may, I think the concept of exploring the nerve is a lot less frequent. However, sometimes in young individuals who present with facial pain, like trigeminal neuralgia, there have been reports that, quote, exploring the nerve have uncovered vascular contact.
Let me ask, there are some neurosurgeons out there that say microscopes are old-fashioned. We're going to use something called endoscopes. And do you have are you going to leap into that discussion and say that there makes a difference what kind of scope you use when you do the surgery?
So I think that's great. So an endoscope is a tool, just like a microscope. And, I think that's part of the equation of surgery. It's not the only factor. I think just like you have tools in your toolbox, there are times when it's appropriate to use one and when it may not be appropriate to use, or may be more appropriate to use a different tool. So, I think for people who've done a lot of microvascular decompressions, there are times when people may bring in an endoscope. The endoscope allows you to not truly look around a corner, but be able to kind of look obliquely around a corner when you have a strong suspicion that an artery is there and you just don't see it touching the nerve. But sometimes, I think it's more important that, a surgeon's comfortable with both tools. And it's, I think, the experience that's more important than just the endoscope versus the microscope.
So it's the brain behind the hands, not just the hands and the eyes. It's the experience. So let me take this patient to the next step. So you've seen this woman. She's described this history. She tells you she's taken this convulsant medicine, and it makes her maybe she uses the term zombified. She gets really uncomfortable with it. And you have this image. What's next?
So I think when you have a patient who's gotten to a point where medicines have failed them, surgical options are certainly a very reasonable option for patients with trigeminal neuralgia or this facial pain. At that point, the options for the patients are, one, they can go back and try other medications. There are different classes of medications. There's things such as Lyrica and gabapentin, and some people wish to try that, and some people need combination therapies. And for others, they're very tired of the side effects of the medication, and they want to seek something that maybe that would get them off their medications. And so, at that first decision tree, if they decide that they want to come off their medications, then surgical options are the next step. And, you know, in terms of what I think about for individuals, you know, in terms of treatments, there's something like the microvascular decompression, which many people believe the actual contact of the artery and the nerve, and the artery rubbing on the nerve, probably causes what they call demyelination, or rubbing away the insulation of the nerve, to ultimately cause this pain. If the concept is to fix that, and when you decompress that, when you decompress that nerve, people can do really well. 80% of the time, their pain is gone. Someone young like this person that we're talking about may be a great candidate for that surgery. I always tell my patients, yes, it's invasive, but it's not a destructive procedure, and it can offer you a long-standing relief. On the other hand, some people are not so keen on getting open surgery, and there are other things such as a rhizotomy, which is a percutaneous or a needle procedure where they usually, where we put a little or a long needle here while patients are sedated or asleep, and literally burn the nerve or ablate the nerve. Or another option is to do radiation.
So let me take things in a different direction. Microvascular decompression. Patients will say, my God, that's brain surgery. And why can't we just do the simple thing, the thing with the needle or radiation, where I don't have to be in the hospital? Why do the fancy brain surgery at all if the other thing works, or does it? Or is it different? How are they different?
Right.
That's four
That's
questions.
a great, yeah, I mean, that's a great question. So, you know, I think it comes down to philosophy. Okay. So the microvascular decompression is quote brain surgery. Yes, it's invasive. But at the end of the day, I think there are two important points. You know, with the microvascular decompression, our whole point is to get in and fix the problem, but leave everything intact. You know, I think we all take pride in making the brain look just as pristine leaving as going in for this type of surgery. So, you know, while it's important to understand that, yes, it is a brain surgery, but and it is invasive, but it is not destructive. So the chances of having burning pain or numbness or severe numbness after having a microvascular decompression is extremely low. Whereas if you go down the other path, which is the rhizotomy, for example, you know, from a surgical standpoint, it's much easier to go through. It's a percutaneous procedure. It's a very complex needle injection in some ways, is what I tell people. And you wake up and you just have a Band-Aid on your face. There's no sutures to remove, and you go home and you can go back to work the next day. But the concept of how that works is that it's literally injuring the nerve, or you're causing a burn on the nerve, whether it's a chemical with glycerin or with heat, with what they call radiofrequency, or with a balloon, which is physical compression of the nerve. You end up with in essence, you have a very good chance of getting pain relief, but oftentimes you're left with some side effects. You know, for example, there's a 20% chance of numbness, whereas the less than 1% chance of numbness with an MVD. And there's a chance of developing burning pain or searing pain. And some people can even develop some chewing problems. I've seen people not able to, they tell me the classic thing is, I can't chew a piece of meat on that side. And so those are all small risks, but they're there. And at the end of the day, as we mentioned before, it's an ablative procedure, but it's not a durable procedure. So it's something where it will, usually the pain will come back and you have to do this again, or you'll have to figure out another treatment. And so if you think about someone who's young and does a rhizotomy many times over their life, those risks that I previously mentioned, while they're small per episode, cumulatively could become significant.
You're saying the point is, with the percutaneous procedures, meaning needle procedures, it's more likely that the pain will come back. Why is that?
So I think at the point, you know, if you think about it as the microvascular decompression is truly trying to get to the source of the problem. And many people think it's the vessel rubbing on the nerve, and fixing that vessel rubbing on the nerve will essentially stop the pain. The rhizotomy or the percutaneous procedure is not doing that. The vessel is still contacting the nerve after you do the surgery. All you're doing is essentially injuring the nerve somewhere else to cause, I call it, distract the nerve from a while from transmitting all the pain to your brainstem and to your brain.
Right. The point is the nerve can heal, not the wire, but that insulation can heal. And when it heals, you'd think that would be a good thing. And it is, because sensation that had gone away will come back. But what also comes back is the pain, because the nerve is working normally again. And normally is not normal for this person, because there's that short circuit still. So let me continue on the theme of not everything is perfect and things can come back. And let me show another situation, one of my own, but I'll describe it. So I'm reading this. A 64-year-old woman has had 5 years of stabbing pain in her right jaw, and she's requiring 3,200 milligrams of this medicine called gabapentin or Neurontin, which is a seizure medicine. And for those of you who don't know, 3,200 milligrams is like a world record high dose, but there's still pain. She also has a number of other bowel disease, psoriasis, migraine headaches, hypertension, asthma, gastroesophageal reflux. And there's this MRI that she has that shows this dot right there sticking into the trigeminal nerve on the right side, which is right there. So to cut the story short, she had surgery and she didn't get better. Sometimes that happens. The incidence is published as maybe 10% of patients that have this surgery don't get better. In this case, an MRI was done after the surgery, and to explain what we're seeing, it's a side view of the trigeminal nerve. Where's my, whoops, I don't like to say whoops. This is the area called Meckel's cave. The nerve is here, and there's a blob of Teflon here, and the artery is way up here. It's no longer touching the nerve. I'll just tell you that. There's the nerve, there's the Teflon, there's the artery, they're not in contact. So let's say you saw this situation, what would you do?
So I think you highlighted an important point there that, you know, trigeminal neuralgia is a clinical diagnosis. And so, which means there's no blood test, there's no CAT scan, there's no MRI that can say, aha, you have trigeminal neuralgia. And so when you make a diagnosis of trigeminal neuralgia on clinical symptoms, you are inherently going to find patients who the patients are going to have different causes for their pain. And so, as we mentioned before, there's no, these procedures are not 100% effective. As we quote most of our patients, there's a 70 to 80% chance of a long-term durable relief with a microvascular decompression. And 90% of the time, patients come out with some pain relief, but 10% don't. And I think your patient highlights the fact that there are sometimes other causes for facial pain, and we sometimes just don't know why that is. I think one of the things that you mentioned very nicely in the history is the fact that she has some autoimmune disorders, and I've noticed, and I think many of us, including yourself, have noticed an association with patients who present with facial pain and some of these autoimmune disorders. And so there's probably another cause to it, and oftentimes you don't know. So in situations like this, first of all, usually talk to the patients and advise them to go back to their rheumatologist to make sure that their autoimmune disorder or autoimmune disease is in check. And then, one of the things that we can do when you have a situation like this, if the pain is truly sharp and stabbing in nature, rhizotomies are a good option for patients to at least get them out of pain. We may not know the cause of the pain, but we can actually get them some relief and make the quality of life better.
what's your quote rhizotomy of choice that you would do in this situation? What approach do you use towards a rhizotomy?
So in general, I think for rhizotomies, I've been more partial to trying with starting with glycerin rhizotomies, and then if that's not strong enough, I'll convert to radiofrequency or a combination of glycerin plus radiofrequency rhizotomies.
All at the same time, or one after another?
Well, so usually I'd like to start with the glycerin, and then if the glycerin doesn't work, I just add a glycerin plus radiofrequency rhizotomy for the patients.
But I mean, do you do the glycerin and then wait 6 months? Do you wait 6 minutes? Do you wait a year? How do you go about if it doesn't work, the glycerin, quote?
Yeah, so I usually try to wait a week or two because I think it's a bell-shaped curve. Some people get immediate pain relief, but I've seen the relief be as long as, I mean, the delay in the relief take as long as 7 to 10 days. So I usually say if it hasn't worked at 2 weeks, it's not going to work, and we come back and we do something stronger.
So you don't believe in what I call the Johns Hopkins double whammy?
Oh, you mean starting with the glycerin and radiofrequency rhizotomy?
Yes.
You know, in some cases, like patients with MS, I may be more inclined to do that because I found that glycerin isn't as effective alone. And I think that's a combination. In an older person with MS with a lot of atrophy, I may be more inclined to do both. And the younger person with MS who has very nice nerve volume, you know, on the MRI, the nerve looks nice and thick, I may be inclined to start with a glycerin. But sometimes I'll do a double whammy in certain situations, as you say.
All right. Well, this was my patient, and I used my preference. I did a balloon compression shortly after her surgery failed, and she's fine now, very happy. So not everything is perfect, is the point.
Right.
Despite neurosurgeons.
Yeah, but I think as you mentioned, there's still great plan B and plan C. The rhizotomies are still a great option.
And the point is, you have the option of doing something else. You're not just a one operation, one hammer person. And that's the point of a center or a specialist, is that you have a variety of options. If one thing isn't the right thing, you go to the other thing. And as long as we're talking about the other thing, what's your thoughts on radiosurgery?
So I think radiosurgery is also a great option. To be clear, you know, all three of these procedures, I always tell my patients are good, good, and good. It's just for certain people, you know, for different people, certain options are better. And, you know, I think radiosurgery is a great option. It's been, you know, we've had great data on radiosurgery since the mid-1990s with large studies. And so radiosurgery is another option. It works very much in the same concept as a rhizotomy, in the sense that you're essentially injuring some of the nerve fibers to distract the nerve and stop that short circuiting. The difference with radiosurgery and rhizotomies is that with radiosurgery, it usually takes somewhere between 4 to 6 weeks before you start feeling that pain relief. It's not immediate. You'll get the treatment and you'll walk out saying, I still feel the same as I did walking in. But you have to understand it takes 4 to 6 weeks. And the dose of radiation is quite high. So you can probably only have that treatment at max twice. Whereas with the rhizotomy, you know, I've done it many times in certain individuals, and it's been a great option for them.
So do you make a judgment in terms of how severe or urgent the surgery is? If the pain is truly terrible and uncontrolled, can they still have radiosurgery if they have to wait 6 weeks, or do they have to go to something else instead? Is there a judgment you have to make?
Right. So I think, as you alluded to, every patient is different, and which treatment option is ideal for them is you know, again, different based on many different things. For example, if a patient came into me and said, I'm on blood thinners and I cannot come off blood thinners under any circumstance, even though they're in horrible pain and can't eat or drink, radiosurgery is probably the best option. If they are young and healthy and they're in horrible pain, getting them to an MVD may be the best option for them, because this is something durable. And, you know, for people who are very busy and say, I just can't take the time off for surgery and I can't take the 4 to 6 weeks to recover from surgery, or the 2 to 3 weeks to recover from an MVD, I mean, then, I think a rhizotomy is a great option. So I think.
Well said. The concept is that someone who takes care of this disease has to have the judgment to put the patient, not to have the patient tell you what they want, but to participate in the discussion, because something may not be right for one person, but it may be right for the other. And so there is the role of the physician involved. There still is a role for the physician. It's not by equation, and it's not something where you can read a book and says, this is the best, this gives you the best quality of life. The best quality of life depends upon the physician and the patient interaction. So this is wonderful. I'm not sure where I want to go next, but I've got a slide, because you mentioned something about you're looking for a tumor. So let me show you something like this slide. This is a woman who was 82 years old, who had severe stabbing pain in her right face that had a constant burning component. She's taking a lot of this medicine, gabapentin, 1,000 milligrams, but she still has severe stabbing, and she's got this burning, but if you ask her carefully, she says, the burning I can live with, get rid of the stabbing. In addition, she has a problem with the movement of her right eye. There's another nerve that's not working right. And I've got an arrow here, so people won't understand everything, but this lady's head. This is a tumor. She has a tumor here, which is right near the trigeminal nerve, and that tumor is in the area also of Meckel's cave. So it infiltrates Meckel's cave, and it goes a little bit into the space between the base of the skull and right up against the trigeminal nerve. And the question is how to treat an 82-year-old woman who's in good health, but still 82 and has risk, with severe stabbing pain that's not controlled with medicine. Now I'm going to put you on the spot. Mm-hmm. I didn't tell you about this ahead of time. How would you think about someone like this?
Well, I think you alluded to it first of all, which is to try to get to the core of the problem, which is, her quality of life. And so we want to understand which part of her pain is worse. Is it the sharp stabbing or is it the burning pain? And as you alluded to before, the sharp stabbing pain is the part that's giving her the most difficulty. And then the second part is the actual disease or the pathology. And if you look at the tumor, it's likely called a meningioma, and it's a benign tumor. In someone her age, the chances of that tumor growing to be so big and creating a problem, besides the eye problem, for example, life-threatening things as like brainstem compression, is highly unlikely. So if you are in a situation where you're more than likely going to just monitor the tumor and her quality of life is terrible, then you can focus on some potential treatments to try to help her quality of life. Now, in this situation, in a patient who presents with a mixed picture of what we call atypical and typical facial pain, and the predominant symptoms are the sharp stabbing pain, in my, one of the things I like to recommend and give as an option for patients is a rhizotomy. Now, in patients who have meningiomas, I've had very good success doing a rhizotomy for patients and get them, and like I said before, it's a very short procedure, and they can come out, and go back to work the next day or go back to their hobbies and have a very good chance of being pain-free from their sharp stabbing pain. Now, it's a bit of a double-edged sword, because with the rhizotomies, there's a chance that we could exacerbate or make the burning pain worse. And so that's something that we spend a lot of time talking about, and that's a risk-benefit ratio. In my experience, at least with the first one, usually I try to do a glycerin rhizotomy. I think it's a little bit more gentle, and I think there's a high chance of that any bad side effects being reversible. So in her situation, I'd be more inclined to offer her a rhizotomy if the medications have failed her.
I think you're on the same track I was thinking. I'm going to tweak you some more in that, let me show the picture again. Is it up? Can you see it?
Yeah.
I thought of that, and this is my patient. The problem was the tumor was in the area of this Meckel's cave, and my needle had to go through the tumor. Do you think that could be a problem, or do you think it's possible to get to the nerve if you have to go through a tumor that's in the way?
So it's interesting. I've had several patients with tumors in Meckel's cave, and in some ways, you know, when I put the glycerin in there, I think the glycerin is, if anything, going to stay in Meckel's cave a little longer. And so I've had some really great results where I've had people getting, you know, many years of pain relief in that area. Of course, there's a chance you could cause bleeding by poking into the tumor there, but it's such a tight compartment and it's pretty walled off that I've just not had that issue. You can counsel people. I mean, I do counsel patients that there's a risk that you could cause worsening of the double vision, but as part of the standard consent, but I've just not seen that.
Okay, now you're teaching me something, because I was afraid of that. And so what we ended up doing was going with radiosurgery. And this is a not so clear image of what shows is the trigeminal nerve after the radiosurgery. And this white dot is the abnormality in the nerve created by the radiosurgery. We did not radiate the tumor, which, as you correctly said, it's benign. It's not going to grow. Leave it alone. The problem is the nerve. So we radiated the nerve, and she's a happy camper. So there are several ways to do it, but your approach is interesting. You just taught me something. So,
and can I make one comment? I think you also make a very important point. I think you and I have seen many patients who've come to our clinic with patients who were treated with radiation for the tumor itself. And the radiation dose that we give for treating a trigeminal neuralgia patient is something on the order of 70 gray of radiation. And when people treat a meningioma in that area, the treatment dose is usually around 15 gray. That is, you know, more than 4 times. There's more than it's almost 4.5 times difference in terms of the dose. And in fact, I've seen people get a lot worse when they've treated with those lower dose of radiation. Have you noticed that too in your practice?
I have a patient who was treated with radiation to the tumor, which stopped the tumor from growing, or maybe it wasn't going to grow, but they still had their trigeminal neuralgia. It didn't do a thing for it. So that's what I've discovered. Yeah. You can't treat the tumor. You got to treat the disease, which is the nerve. Yes. Right. It's a really subtle point, but it's one that I see a lot of people make mistakes in. So you're right. Let me go to some of the questions people have. One question, since we're talking about rhizotomy, is a patient ever too old for a rhizotomy?
I don't think a patient's ever too old for a rhizotomy. But I think that a patient could be too sick for a rhizotomy. For example, if they have bad heart condition and they can't come off the anticoagulation, or I think those are situations, but I don't think age is.
I had a woman who was 96 and had a successful rhizotomy, and she got a recurrence at 102 and came back. And I tried to treat her at 102, and I was able to stop the pain, but it's very hard at 102. That's kind of a world record. Glycerol. Can you repeat a glycerol rhizotomy successfully if it's not successful the first time?
So I think if a glycerin rhizotomy works for you the first time, I think it's certainly a great option the second time. But if it doesn't work, then I think oftentimes you want to consider doing another something different. And like you said, there are other options for rhizotomies, like the balloon compression. There's the radiofrequency, which is the heat, or a combination of glycerin and radiofrequency.
So you would tend to switch to another tool if something didn't work, rather than repeat the same tool.
Right. And I think that highlights the fact that we have multiple options for our patients.
That's the important point, because another one of the questions that was submitted is that someone had a balloon compression, which worked for a number of years, and then they came back with recurrent pain and had another one, and it didn't work. So the question is, what next? And I guess your answer is going to be, try something different. Don't keep doing the same thing over and over again if it isn't working. And
Right.
that's the point, is people need to see someone like you who has the ability to move between treatments, because it's not going to be necessarily through a lifetime one treatment that works. We want to talk a little bit about the difficult problem, what people call atypical facial pain, or patients with constant burning pain as the predominant feature, and what in your practice you would be able to do to help them. We're getting to the difficult questions now.
Right. Well, I think the difficult question is this. So, you know, when we talk about atypical, I classify them kind of as two different types. So there are the patients who present with what I call a mixed picture. They have, for example, like your other patient, they could have a combination of sharp stabbing, electrical pain, but on the other hand, they could have a constant burning or aching pain. And in patients with that type of mixed picture, oftentimes it comes down to quality of life. And the procedures that we've mentioned before are very good at taking away sharp stabbing pain. And so if sharp stabbing pain is the predominant symptom and their quality of life is better, then we could potentially offer some of these procedures that we previously mentioned. But if it's purely burning pain or purely atypical pain, I think that at times we could potentially exacerbate and make things worse for our patients. You know, a rhizotomy, I think, as I mentioned, could be a double-edged sword. And so a person could be coming in with burning, searing pain, and we do a rhizotomy, and we could leave them going home with severe numbness and potentially exacerbation or the same burning pain. And so in those situations, I think it's important that you have a group of people that you work with. We have, you know, people in our pain division that have special interest in facial pain, and we try to work with them to see if they can do other things, such as other medications, stimulators, and such.
You use that word stimulator, so it's time to ask about, you use any form of neuromodulation is the term. You want to talk a little bit about neuromodulation and how you might or might not use it in your practice?
I generally don't do the neuromodulation in my practice, but we do work with pain specialists who do the neuromodulation. And neuromodulation is essentially trying to provide an electrical or add an electrical stimulus to a patient's area of pain directly through a wire. It's usually you modify that electrical signal through frequency and what they call intensity. And sometimes you can find something that will essentially kind of distract that nerve to essentially, as they say, modulate the pain to oftentimes make it better. And, you know, when people do that, oftentimes they go for what they call a test run. And, you know, they get the needle, they get the wire placed, and they go home with, or they hold a stimulator for a while. And if that helps them, then you do a small surgery where you take that wire, place it in the area of pain, and tunnel it down, and you have a little battery pack that's tucked near your clavicle or in your chest.
I think your point is saying you personally, the surgeon personally may not be the expert in everything, but if they have a facility where there are experts in areas that the one person isn't, that's just as good, if not better, as long as you have that diversity of options available to the patient. That's what you're saying. In your center, there are other people that do that. That's their expertise, and they can be involved. But you don't have to be the expert in everything.
Right.
Even if you are at Johns Hopkins, you don't have to be the everything expert. I'll allow you that. So let me move to another area, which is a difficult area. We're working into sequentially more difficult kinds of situations. Let me pull up another slide. This is 58-year-old woman who developed right ear pain after going swimming. She says the pain is burning and tingling, but also throbbing. And I'll take you through these images. This is the right trigeminal nerve, and the arrow points to some kind of a vessel touching the what's called distal part of the nerve, which if we look at it straight on, that's the nerve, and there's the vessel on the top of the nerve. And here from the side, this is Meckel's cave, and that's the nerve going into the brainstem, and there's that little vessel. So someone, not me, decided to do trigeminal nerve blocks to help this lady's pain, and they didn't do a thing for her. They made her temporarily numb, but they didn't stop the pain in her ear. Shall I ask what you would think about next?
So I think that in this situation, it's, as you mentioned in the first line, it's pain in the ear, not in the face. And I tell people it's a different wire for the ear than the face. So, you know, if you, it's like saying that, I always tell my patients this, it's like we address the dining room light and the dining room circuits. I mean, the electrical wires in the dining room, and having pain in the ear is just a different room. So manipulating the dining room is just not going to fix the problem with the garage door light, for example. And so I agree with you.
Let me show you another slide of the same woman's imaging, where we look at another wire, and I'll take you through that. This wire is called the glossopharyngeal nerve, and there's a loop of a big vessel right pushing in on that wire, which is a little tricky to see on straight on view. There's the big artery, and I think the nerve fiber is right there. And there's that big artery, and there's the nerve fiber on the side view. So I'll take it back and let you talk about what this is all about.
So I think, as you allude to, the vessels can contact different nerves and different wires. And when they do that, for example, with glossopharyngeal neuralgia, people can have different symptoms. In general, I've seen a little bit more of pain in the throat and burning with the glossopharyngeal neuralgias, but you know, people can have different variations of the pain. And people can also, I've seen people develop something called, or been diagnosed with something called geniculate neuralgia, which is another wire off the 7th and 8th nerve. They call it the nervus intermedius. And so, you know, if the patients have a certain type of characteristic of pain, predominantly, usually people say it's still sharp and stabbing down the back of the throat, these decompression procedures can be applied to different nerves and still be successful. But again, you want to make sure you have the right symptoms and the right anatomical association for MVDs in different places.
You can do a microvascular decompression of the glossopharyngeal nerve as well as the trigeminal nerve. Okay. Right. Are there any other options for treating glossopharyngeal neuralgia that you can think of that might be helpful besides the brain surgery if they have this kind of problem?
Well, generally people do medical therapies, and I think one of the biggest things I've learned is that I usually have the glossopharyngeal neuralgia patients see ENT, ear, nose, and throat doctor. I've actually picked up or seen 3 cases of malignancies that have come, a tongue cancer and a throat cancer, And so it's something that we always want to make sure that we're trying to make sure we try to find the cause of the pain. So
Yeah.
those are the main things, medical or
There's gland that is a common problem that is not well thought of. It's called the parotid gland, which is the salivary gland, and a tumor in the salivary gland where the trigeminal nerve passes through can cause burning pain in the face, and every so often one has to think about a tumor of the parotid gland when nothing else makes sense. So you're right, exactly right, to say, wait a minute, we need some other help. And I myself have had the ENT doctor say, you're missing something here, there is a tumor. And so that's a great thing to have another element in the team. Right. I will move on to the next difficult situation. We still have time, okay? 68-year-old man who had multiple sclerosis beginning 13 years ago. At that time, something called a plaque had been seen in the pons, which is in the area of the trigeminal nerve on the right side. 4 years later, he developed burning pain in his face on the right side. But at no other time was there any other sign that his multiple sclerosis caused any other problems. And then persistent imaging of that abnormality, this plaque, this sclerotic plaque, which is the typical thing of multiple sclerosis, it never enhanced, it never changed. Now this one's a little trickier because in this image, this vessel here on the right side, which is probably best seen, well, let me get my, hold on. I don't know if it's easy to see, but this is the nerve, and then there's a vessel running right along the side of the nerve on the right side. So the problem is what to do with the patient with multiple sclerosis, with constant burning, not stabbing pain of long duration. Any ideas and thoughts?
Yeah, so this is a very difficult case. It's a difficult situation for the patient because obviously they've had a very poor quality of life from the burning pain if it's been that long. You know, in my experience with patients who have burning pain, I've not had as I think it's one of those situations where I think a rhizotomy or radiosurgery would not be a good idea, or I would not advise that for patients with this because I think the burning pain would be worse. I found in general when patients get an MVD with burning pain, it's not as successful. And so, again, as I said, I would probably utilize some of my colleagues to try pain management. I do have to say I've read and I've seen some case reports of people doing microvascular decompressions and reporting successes. So I'm not saying it's the wrong thing to do, but I've seen some people do that. And sometimes I'll say it's a great thing that, you know, it's not just Hopkins, but, you know, with the Trigeminal Neuralgia Association, as you can see, we all are quite collegial. I think everyone has developed a great experience. It's, you know, it's not uncommon, for example, like you and I share patients and get different opinions.
So I'll show you what I did. This is an intraoperative picture of the right trigeminal nerve. This is the right trigeminal nerve. This is the brain here. This is what's called the facial nerve. This is what's called the motor root of the trigeminal nerve, which controls the chewing muscle. And this is that big vessel right up against the motor root of the nerve. It's a vein. And in this case, I moved that vein away. It did not cure the patient, but it made him, what he says, 30 or 40% better. So it's not perfect, but he's better. So I don't know what the solution is, but I think you're right. There's not always an obvious route to take. But if a patient's in difficult pain, what are you going to do? As long as you don't hurt them.
Right.
It's time for me, because we're running out of time. You are at Johns Hopkins. The question is, what ongoing research are you aware of to change the treatment of trigeminal neuralgia? Because you got the place that could be doing it.
Right. Well, so for example, we have studies going on where we think that trigeminal neuralgia could be an inflammatory condition. And so most of our patients, we've secured funding to do some studies where all of our patients who get, for example, microvascular decompression are asked if we could take some of their, what they call CSF samples. That's the fluid that's surrounding the brain. And we often have to drain some of that to get down to there. And that fluid usually goes into the suction canister and gets discarded. So we take that and we do, and take the blood to see if we can, first of all, we take the blood, those fluids, and we actually look for different inflammatory markers, hoping to find new targets. By taking the blood, we've also done some genetic studies to see if we can find some sort of cause of looking specifically at pain receptors. And you know, at the next level, we actually have collaborations where we've now made our repository of samples available to other researchers to collaborate with, so that we can, if other people have other ideas, we're trying to make that accessible. And so I think, as you mentioned, that being a center here like this, it affords us the ability to talk to patients who, if they consent and they're generously donate their samples, help us in trying to figure out the cause of trigeminal neuralgia. The second part is that we have clinical trials. For example, we have an ongoing trial with a new generation of pain medication that's not, you know, that's not similar at all to trileptal. And you know, patients who have atypical or typical pain are actually eligible for this study, and they get treated with this. So these are things that we're doing. We're trying things with clinical trial levels, and we're doing basic science where we're trying to understand this disease.
So I'm going to sound like a talk radio host and say, final words. It's up to you. Anything you'd like to conclude with?
Well, I think that you know, there are many of us that are very dedicated to taking care of our patients, and it's our privilege and truly an honor to take care of them. I think it's, and I say that to our patients because we truly mean that. And you know, I think that we focus on two things: trying to get rid of the pain and trying to make the quality of life, and to get rid of the pain or make your quality of life better, and to try to figure out the cause of the pain. And sometimes we're able to accomplish both, and sometimes we're not. And if we're not able to find the cause of the pain, we still have good tools to try to at least make you comfortable and ease that pain.
Thank you very much, Dr. Lim. I hope you all benefited from this, and if there are questions, as I'm sure there are, that haven't been answered, Ms. Turner says they can be submitted, and we'll do our best to respond to them. Thank you all.
Thank you.
And thank you, Dr. Brown and Dr. Lim, for taking the time to do this. Very informative, great information. And yes, we've gotten quite a few questions, so I will do my best to try and get back to everyone. And this webinar has also been recorded, so that will be available on our website. Next webinar will be Wednesday the 17th, where Dr. Brown will be interviewing Dr. Chang, who is with the Department of Neurosurgery at Stanford University. So keep an eye out for that information. Lastly, and most importantly, this fall, we're having our national conference at UC San Diego, November 2nd and 3rd. And it's a great opportunity for you to speak directly with Dr. Brown, Dr. Lim, other doctors on our medical advisory board, and just meet with people who experience the same pain that you deal with. So visit our website for more information on that, facepain.org, or please feel free to reach out to me directly my email should be in the registration that you received.
Amy.
If I could make one other last comment, I just wanted to say thank you again to Dr. Brown, and I want to also acknowledge that, you know, our center is comprised of great people, so I want to acknowledge that, you know, it's not just me, but, you know, my partner, Dr. Chetan Bedagata, who does trigeminal neuralgia, and our nurses and our PA, Carla. So I want to say thank you to everyone.
Thank you. All right, well, have a good evening, everyone.
Thank you.
Now, if I can figure out how to stop.